So now we shall discuss uses of opioids, therapeutic uses of opioids, mainly morphine. So morphine, we have learned so far, it can be used as analgesic, especially for the visceral pain, traumatic, visceral, ischemic pain, microinfarction, post-operative pain, burn pain, cancer pain. So these are the specific uses of the morphine or other opioids: visceral or ischemic pain, post-operative pain, burn pain, cancer pain. Opioid should not be restricted in case of pain or terminal illness. Often there is a misconception that it should be used only in cancer pain, but in the above situations also we can use morphine or other opioids, especially post-operative burn patients, visceral pain due to other reasons. It can be very effective. But for other chronic conditions, due consideration must be given to their addicting liabilities, because often due to their addiction proper liability, patients tend to take it chronically even if there is no pain. So you have to be cautious about that. Neuropathic pain responds less predictably. Transdermal fentanyl is a suitable option for chronic cancer and other terminal illness pain. The patch produces analgesia after 12 hours, and it can be effective and provide a analgesia of uniform quality if the patch is changed every 2 to 3 days. But for majority of the severe and longer lasting pain, if opioid is not successful alone, we can add NSAID, and NSAID opioid combination actually helps to enhance the analgesia while keeping the opioid as well as NSAID dose low. So if opioid is not successful alone, we can use NSAID, because that will allow us to induce analgesia keeping the opioid dose as well as NSAID dose low, and thus have less chance of adverse effect. Acute left ventricular failure, a very specific use, or which is also called pulmonary edema. It is due to congestion in the pulmonary circulation. There is symptom dyspnea, and this is very acute condition. And morphine is a very effective drug. It affords dramatic relief by reducing the preload on heart due to vasodilation and peripheral pooling of the blood. So morphine, it is a vasodilator, we have known that, because it releases the histamine, so that's why it causes vasodilation and reduced preload on the heart due to peripheral pooling of the blood. There is shifting of the blood from pulmonary to systemic circuit, relieves pulmonary congestion and edema. So what is the effect of morphine? It causes vasodilation, so there is reduced preload, and blood is pulled peripherally. That's why there is reduced venous return. Reduced venous return means there is less blood coming into the right atrium and then into right ventricle, and if less blood is coming into the right ventricle, then from right ventricle less blood will go into the pulmonary artery, and there will be less pulmonary congestion. But as it is not so much vasodilating in pulmonary circulation, so from pulmonary vein normally blood will come into the left atrium and then to left ventricle and then to systemic circulation. But when they reach to systemic circulation, due to this venodilation, the blood is retained peripherally. That's why gradually there is shifting of the blood from the pulmonary circulation to the systemic circulation, because of less venous return, less blood from the ejected from the left ventricle into the pulmonary artery. So it releases the pulmonary congestion and edema dramatically. It causes respiratory depression, and that is beneficial here, because in acute left ventricular failure, patient is having severe dyspnea, patient tries to increase the respiratory rate, but as morphine depresses respiratory center, so it allays the air hunger. It also cuts down the sympathetic stimulation by calming the patient and reduces the cardiac work. So it is left ventricular failure commonly seen in patients of MI or hypertension emergency, also indicated to relieve pulmonary edema due to lung infarction. So it is a very commonly asked MCQ question in the explain why acute left ventricular failure, why morphine is used. The reason is this. But in conjunction with this, morphine should not be used in treatment of cor pulmonale, or that is the right heart failure, which is predominantly seen in the patients of COPD. So what will happen? So why cor pulmonale happen? Cor pulmonale happens due to COPD, because in COPD there is persistent hypoxia, and this hypoxia induced pulmonary vasoconstriction is actually causing the right heart failure. So pulmonary vasoconstriction and right heart failure, that is called cor pulmonale. If we use morphine, then morphine further reduces the venous return, and there is further less blood go into the pulmonary, further less blood will go from the right ventricle into the pulmonary artery circuit. So, and the less blood in the pulmonary circuit actually will tend to further aggravate the hypoxia, and this will aggravate the cor pulmonale. So, in cor pulmonale, morphine should not be used, but in acute left ventricular failure, morphine is drug of choice. And in cor pulmonale, as it is right heart failure, already patient is having peripheral edema. So if we use morphine, which by reducing the preload, that will cause further pooling of the blood in the periphery. That's why it should not be used in the cor pulmonale or the right heart failure. Okay. Next use, pre-anesthetic medication. Already we have discussed morphine, pethidine, as well as fentanyl. It can be used in some pre-anesthetic medication. Balanced anesthesia and surgical anesthesia, fentanyl, pethidine, alfentanil, dimefentanil are an important component of the anesthetic techniques. Relief of anxiety and apprehension, especially in the patient of myocardial infarction or in patients of internal bleeding, morphine can be employed. Cough and diarrhea, codeine or its substitute widely used in treatment of the dry cough as an antitussive agent. Diarrhea, the constipating action of codeine has been used to check diarrhea, but now codeine is not available in India, so cannot be used. We cannot use codeine as antitussive or antidiarrheal agent. What we have now, we can use some peripheral mu-opioid receptor agonists like loperamide, like difenoxylate. So loperamide and difenoxylate, they are peripheral mu receptor agonists present in the lower large intestine, and they decrease the intestinal motility. So they are an anti-motility agent, mu agonist used in treatment of the diarrhea, non-infective diarrhea mainly. Another agent is resicadotril. Resicadotril, it is an enkephalinase inhibitor. Enkephalin, you know, it is an endogenous opioid. So enkephalinase inhibitor means there is resicadotril increase the enkephalin level, which is actually decreasing the intestinal secretions. So it can be used in secretory diarrhea. So resicadotril, loperamide, and difenoxylate, they are used in treatment of diarrhea, and they also act by the opioid mechanism peripherally. Synthetic opioids exclusively used are difenoxylate and loperamide for the diarrhea. In diarrhea, in conjunction with diarrhea, we know that morphine is a drug which can cause constipation. Okay, so constipation due to morphine, it has been seen that there is no tolerance with constipation. That means for analgesic purpose, tolerance is seen. That means to have the same level of analgesia, morphine dose is gradually increasing, need to be increased. But this increased dose will also increase the constipation, but as there is no tolerance, so constipation due to morphine will also increase if we tend to increase the dose, and there is significant constipation in most of the morphine addicts, and we can use some drugs like albumin and methyl naltrexone in treatment of this opioid induced constipation. Okay, so for diarrhea we can use opioid agonists like loperamide, difenoxylate, but morphine or opioid induced constipation we can use albumin or methyl naltrexone. Remember this. So far we have discussed, I have the following questions. Number 1, what are the two major indications of the morphine? Number 1, what are the two major indications of morphine? Number 2, tell 3 conditions where pethidine is preferred over morphine. Number 3, pethidine can be used in treatment of myocardial infarction. True or false? Pethidine can be used in treatment of myocardial infarction. True or false? Number 4, which effect of morphine do not, which two effects of morphine do not show tolerance. Which effects of morphine do not show tolerance? Number 5. What is the major indication of methadone? Number 5. What is the major indication of methadone? Okay. So let's continue. Answer me this in writing. So after this commonly used opioid agonist, we can now discuss complex action opioids and opioid antagonists. So there are some agonist antagonists. That means there are 3 receptor variety, mu, kappa and delta. Some drugs are there which acts as agonist on some receptor and antagonist on some receptor. So these are actually agonist antagonist like kappa analgesics. So nalorphine, pentazocine, butorphanol. They are actually kappa agonist but mu antagonist. There is some partial mu agonist plus kappa antagonist like buprenorphine and pure antagonist like naloxone, naltrexone, nalmefene. So they are called complex action opioid or opioid antagonist. So agonist antagonists are kappa analgesic, that means they are kappa agonist plus mu antagonist, nalorphine, pentazocine, butorphanol. Partial mu agonist plus kappa antagonist is buprenorphine and pure antagonist is naloxone, naltrexone, nalmefene. So pentazocine, it is weak mu antagonist and more marked kappa agonist reaction. So if you remember the kappa effect, this is called dysphoria. That means patient will feel bad if drug is taken. That's why pentazocine has a drug which has mu antagonistic effect, but due to its kappa effect it causes dysphoria, and that is actually beneficial because there will have less chance of developing addiction. So analgesia caused by pentazocine is predominantly spinal, and parenterally it is 1/3 that of the potency of the morphine. 30 mg pentazocine is 10 mg morphine, but ceiling effect is lower. Respiratory depression and sedation are also 1/3 of the morphine. Tachycardia is seen due to sympathetic stimulation. So once again, due to sympathetic stimulation there is tachycardia. That's why pentazocine also should be avoided in treatment of myocardial infarction. Better to avoid an ischemia myocardial infarction. Biliary spasm and constipation are also less severe, and due to this kappa effect there is some psychomimetic effects appear in higher dose. Abuse liability is rated lower because of this dysphoria, and in morphine dependence it precipitates withdrawal. So what is withdrawal? So withdrawal means when a drug is agonist is chronically taken, if it is suddenly discontinued, patient will have some opposite features that of the agonist, and if there is withdrawal symptom, then it confirms that patient was chronically taking the drug or patient was dependent on the drug. So actually withdrawal symptom actually proves that patient was dependent on some drugs. And also withdrawal can be exhibited if an antagonist is given suddenly, as pentazocine is a mu antagonist, and in morphine dependence it can precipitate withdrawal because most of the effects of morphine are mu dependent effect. So mu receptor dependent antagonism precipitates withdrawal, and considerable fast metabolism is there and indicated for postoperative and moderately severe pain in burns, trauma, fracture, etc. It has potential for the dysphoric psychomimetic effects. That's why it should be avoided in cancer patient, because pentazocine is used for some short-lasting pain situation when there is no chance of abuse liability, addiction liability. But in cancer patient, we need to continue opioid for longer time, and we do not want that patient is dysphoric or avoids the drug. That's why it has limited utility in cancer patient.